morning, everyone. I'm Nancy Chien. Very glad to be invited here, and I'm to meet old friends and also meet new friends. So my connection to Pompe disease actually started from the quite early pivotal trial. At that time, actually we learned that after YT Chien from Duke moved back to Taiwan, we had the first case to be treated. So during that time, we understand that the treatment need to be early enough. Otherwise, we could not make things reversible. However, we could not make early diagnosis quick enough, because then once they have the clinical symptom onset, it was still too late. So we learned that if we could do the early diagnosis and early treatment, then we can have the opportunity to reverse some of the muscle cells during the infantile onset Pompe disease, the most severe phenotype. So that's the reason we, under Dr. Paul, who was late, we initiate the Pompe newborn screening in the world, and back to 2005. And then you may understand that for Pompe newborn screening, actually we collect a sample from every baby born in our territory, and then we can measure the enzyme activity from the samples. And now, actually, we have more advanced technology to measure the GAA enzyme activity from the dry blood spot in a multiplex platform. So, besides the Pompe enzyme, actually, we can measure, for example, the enzyme for MPS 1, MPS 2, and some others, lysosomal storage disease. And then once we detect the sample has low enzyme activity, we need to confirm if the sample comes from a baby with Pompe disease. So we need to see the babies initially, but now I understand that many programs actually can do additional tests, including NGS test, to differentiate the baby have true positive conditions or false positive conditions. But remember that we are talking about fast diagnosis, so we need to understand the time frame. I mean that if we need, for example, 2 weeks to do the NGS to make the diagnosis, that may be too late. So in compensate that, probably we need to see the patient directly, because that we can understand if they have the cardiomyopathy in that baby, so we can make the decision immediately. So I'm glad to understand that in the United States, probably almost 90% of babies now have the access to do the newborn screening for Pompe disease. So you already learned that we demonstrate the overall survival advantage in the newborn screening, identify babies. Also, we demonstrate the advantage in the ventilator-free survival program. But during these years, actually, we also learned from our patients that even they can be treated as early as 1 or 2 weeks, they still have something happens. For example, the distal muscle weakness and the loss of motor functions at a later age. So because we also discussed, many our colleagues here, that we understand that the dosage for the infantile onset Pompe disease may not be adequate, as Dr. Rousseau mentions. So we try to increase the dose in our patients, even they have the early diagnosis, early treatment. And later we understand that they may need higher dose, even they can be treated at 1 week of age. And I think right now we understand more about those biomarkers predictions. So for example, you can see that for babies, if they have a higher urine Has4 or urine group 4 levels, as well as high serum CK levels, they have more risk to lose the ambulatory ability in the later time. So that's the reason we start to treat our newborn screen identified patients with myocytes, the first generation enzymes from 20 to 14 milligram per kilo every other week. And you can see from these figures that their CK levels can be quite normal. Their urine Has4 levels can be quite normal, but at the age of 7 years old, she still present a little bit withering gait, and now we are trying to move the patients to the next generation of enzyme replacement therapies. But on the other hand, we also have newborn babies now started from the next generation enzyme replacement therapy. You can see the serum levels can be decreased even further, and we expect the baby can have more or longer durations to present as normal as children. You already heard about the facial weakness in classical infantile-onset Pompe disease after the long-term treatment. And you can see this is patients from our newborn screen identified babies also present with facial weakness and some speech problems. That's the reason we need to do some more speech therapy, more exercise to decrease the hypernasality, to increase the speech intelligence. And they also have the ptosis phenotype. This is a case from a little bit late treatment, starting the treatment from 3 months old. But for patients even started from newborn screening identify and treatment since birth, she still presents with ptosis and needs some operations to correct the problem. But at least the problem is correctable. I think a more challenge part comes from the CNS part, because as Dr. Henrique mentions that they have some white matters changes. But in our cohort, actually, we can understand that some patients have more advanced phenotype compared to others. You can see from the lower panels that one patient have quite normal DTI fibers, but another one has a terrible fibers destruction. And we now understand that probably the brain changes resulted from the glycogen storage, because again, we can measure the biomarkers from the CSF, and we understand that they have a tremendous amount of group 4 in the CSF, and that will be the next problem we need to conquer. Again, you already heard that we understand their phenotype may have some variation, some advanced quicker or rapid compared to others. So we try to correlate the speed of involvement to the genotype, and we roughly can see the correlation that for severe phenotype, they may have severe problems compared to others. But we also demonstrate that those brain changes may result from the nerve destruction, and also the performance declines. Here you can see the demonstration of their processing speed and some reasoning scores. So that may be the next challenge we need to face, and hope that we can have a better solution in the future. Coming together is the newborn screening identify cases, because we need to understand which one needs urgent treatment and which one needs to be monitored regularly. I already talked about the genotype, but we also have a lot of tools. For example, the GAA in vivo residual activity. We have the storage biomarkers, the damage biomarkers, and also the most important thing is the clinical manifestation. In Taiwan, enzyme replacement therapy can be only initiated if we demonstrate the patient have some symptom or signs onset. So we need to looking for the critical symptoms or signs in that babies. And we could not use the first dry blood spot enzyme activity to do the decision, and we could not use the genotype to do the decision, because you can see here that we understand the red dot, meaning the classical infantile onset Pompe disease has very low enzyme activity, but at the same time, the red dot, meaning the late onset, potentially later onset babies, they also have a quite low enzyme activity. So we need to follow the babies, and here I want to demonstrate you is one caveat that this baby initially presents a mildly ventricular, intraventricular septum thickness, but very soon the sickness resolved. So we follow the babies twice with a quite normal heart presentation, but later at the age of 11 weeks, the cardiomegaly reappears, so that's trigger to do the enzyme replacement therapy at that baby. So I want to emphasize is the regular monitor is quite important, because, for example, this is quite an example of a typical infantile onset patients, and you could see if we did the treatment at that time, the child presents very good motor outcome. The last part I want to mention is for the potentially later onset Pompe disease. Actually, we pay a lot of time and efforts to understand which one needs a treatment and which one doesn't. You could see if we can pick up the right patients and do the treatment on time, the patient can have a quite good motor outcome. But at the same time, we also have some patients, some babies, they can have a very good motor performance without treatment. So we try to understand what's happened in that individuals, and we, as well as Dr. Apple's group, help that we demonstrate that even they have a very low GAA enzyme activity in vitro in the cells, but they don't present those minimal muscle weakness or the specific Pompe-related muscle weakness. So you can see that during 7 years follow-up, they have below normal gross motor development, but those motor development is not declining. So we think that they have a lower risk to develop symptoms even in adults. In contrast, for those definitely genotyped infants, they actually present some earlier signs related to Pompe specific. at the age of 1 year. So I think that currently we can have some genotype correlation, and we can have more confidence that for definitely genotype, they need to pay more attention to understand when they will have symptom onset. But for those classified as variant of unknown significance, probably we don't pay much attention to those individuals, and we can put them into the lower risk to be followed. And for those definitely genotype, now we can do enzyme replacement therapy for those infants, and we demonstrate that with early treatment for those late onset Pompe disease. For example, this I show you two examples. One is our late onset patients identified by incidentally by abnormal liver function. So you can see that when he starts the treatment, he still have very good motor outcome, motor performance, but his CK levels remains very high even with enzyme replacement therapy. And for our babies identified by newborn screening, and then we do the treatment, you can see the CK levels can remain quite normal for up to 10 or 12 years. But actually, we have a new challenge. It's showing here that even in that patients, after 10 years of normalized CK levels, the CK levels went up at the age of 12 years. And you can see another patient demonstrated in the right panels. Again, the CK level can remain quite normal for 7 or 9 years, but then elevate again. So we have the similar challenge is that we need to understand more about the dosage and probably the new formulation of an enzyme replacement therapy. And then we can keep those CK levels as low as possible and remain the motor functions as normal as possible. So this is the current conclusion from our newborn screening program that although initially we think the GAA deficiency, the incidence for GAA deficiency is around 1 in 20,000. But in fact, after we classified those needed urgent treatment of infantile-onset Pompe disease, and we classified those definitely genotype and needs the treatment of late-onset Pompe disease, then we have an almost incidence of late-onset Pompe disease is 1 in 100,000, not as high as previous report. But for those patients, we understand that they have medical need to be followed, to be treated, and then we expect to have more and more promising treatment in the future. So I think now we, with the help of newborn screening, we transform the newborn with infantile-onset Pompe disease as well as the newborn with late-onset Pompe disease into the new phenotype. But we still need ongoing research and also more comprehensive care teams to help them to face the futures. Thank you so much. I need to put this to acknowledge my patient and my family, as well as my dear colleagues to help. Thank you.